Good evening, doctors, and welcome to this evening of scientific session. Thank you for joining and taking out your time for this webinar. While we have termed it as Train the Trainer, we are sure with the expertise that all of you have in using threads, we look forward for a more interactive session. And we're sure that this scientific session would not only give an overview of threads in general, but also a very specific insights into the Definisse threads which we are launching. And before we get into the introduction of the speakers as well as the scientific session, permit us to share a few briefs of Menarini as an organization and an overview of Relife, the division through which we would be bringing the aesthetic portfolio into India. Yeah. So as most of you have already known that Menarini is a 130 plus year old company, and all of you who have been to Florence would have seen this view of the Duomo and the overview of the Florence city, and that's where Menarini is based at. Right from our inception in 1886, there have been several milestones which we have crossed as an organization, including 1992, when we entered into Germany and expanded to the Central and Eastern Europe. In 2003 is when we opened the Menarini Biotech and started developing and manufacturing our own biotech pharmaceuticals. In 2011 is when Menarini entered into Asia Pacific and established its presence in 13 countries in this geography, including India. Yeah, it's now 10 years since we have been invigorating lives in this geography. In 2016 is when Menarini entered into the oncology space by acquisition of a company called Cell Search. And it was in this year when Menarini founded Relife, a new global company which is specialized in dermatology and aesthetic medicine. And the recent milestone was in 2020 when we acquired a company called Stemline, which is an oncology company and made a presence in the United States. This acquisition not only helped us to enter the United States, but also helped us further consolidate our space in the oncology. As of now, we are present in more than 140 countries worldwide, and we are among the top 10 companies in close to 13 countries and among the top 20 companies in close to 30 countries worldwide. And this achievement would not have been possible by the dedicated effort of our employees, which is now close to about 18,000 worldwide. Speaking about Relife, as I said, is a new worldwide company that finds its roots in the Menarini group. And in Relife, we try to make a perfect blend between science, art, and perfection. And if you could see the letter R, which you have used in the Relife logo, represents Leonardo da Vinci's character and stresses conceptually how we could recreate the beauty and the natural perfection based on scientific rules. In Relife, we believe it's time for a new approach that considers the skin as a mirror of a complete well-being. And we consistently talk of conscious innovation. As far as the global expansion is concerned, within a short span of 3 years, we already expanded into 19 countries, including the launch in India as we speak, and in China very shortly. As far as the product portfolio is concerned, we have close to about 40 product variants, both in dermatology and in aesthetic medicine. We believe in a very integrated portfolio approach, offering a great synergy between the dermatology or the medicinal products as well as the aesthetic medicine products. In terms of the dermatology or the clinical medicine products, we have leading brands which include Relizima, which is for the management of eczema or dry sensitive skin. We have got Papix, which is an innovative solution for the management of acne or acne-prone skin. We got Ulife, which is a range of urea-based solutions that offers for the management of cirrhosis to psoriasis. With regard to the aesthetic portfolio, we believe in a very integrated portfolio which focuses on the 5R essentials, which basically talks of resurfacing the skin, reshaping, reboosting, retoning, and restoring. As far as retoning is concerned, we have got a pigment solution program, which is a 3-in-1 kit which consists of a day cream, a night cream, and a preparation cleanser, which has proven effectiveness in the management of hyperpigmentation. For resurface, we have got a Definisse peel program, which is a 3-step chemical peel program for greater clinical results with better safety profile. And for reboosting the skin, we have got Definisse Hydro Booster, which is an injectable that combines the established clinical benefits of hyaluronic acid and glycerol to improve skin hydration, skin tone, and elasticity. To restore the skin, we have got Definisse Fillers, which is a range of hyaluronic acid-based derma fillers, which are produced with Manarini's exclusive and proprietary XTR technology that helps in facial volume restoration, hydration, and rejuvenation. Finally, coming to the product for this evening is Definisse Threads, which are a range of bioabsorbable barb threads with distinct rheological characteristics reflecting the balance of strength and elasticity, which ensures a 3-dimensional tissue repositioning beyond the lifting effect. In the Definisse Threads range, we would be launching the double needle first, and the techniques of that would be discussed in detail today. Following that, we would be launching the free floating, which again, the techniques of that also would be discussed today evening. Following that, we will be launching the Definisse Anchorage Threads, which would be the later part of this year. And early next year, we will be introducing the Bokeh Threads, which is for the lips, nose threads, and eye needle threads, which are for the neck. While we go ahead and launch this entire range of Definisse threads, in parallel, we would also be launching the other dermatological as well as aesthetic products that I had presented before. We in real life believe that these solutions would not only offer innovative solutions in the management of aesthetic practice, but also add value and ensure that you get better treatment options for managing your patients. So with this, I thank you and look forward for a great scientific discussion. Once again, thank you. And Sanjay, over to you.
So good evening, Dr. Fandaro, Dr. Christian, and all doctors who are joined from different parts of the country. Thank you for joining this training on Definisse. As Girisen has already given a brief background about, real life products which will be introduced in India. So it is a very exciting time for all of us at Menarini, and I know many of you are looking forward for using Definisse in your practice. So it's my pleasure welcoming Dr. Salvatore Pero Fandaro, who is today's trainer. Dr. Fandaro is an aesthetic surgeon in Modena and Bologna, Italy. He is a founder and president of Research Center for Injectable Safety and founder and treasurer of Association of Italiana, Trattamento Estetico Bolletino, and vice president of, association called as SIES. So Dr. Fandaro received his medical degree at the University of Modena. He completed his specialization course in general surgery in University of Modena, has been a full-time fellow at the chair of plastic and reconstructive surgery of University of Modena. And also he received a second-level master's degree in cosmetic surgery at University of Milan. He teaches at a private school, PCMA Valet in Bologna, and he is a medical director for Multi-Med Day Surgery Center in Bologna and Quiti Clinic in Modena. Our next trainer for the evening is Dr. Christian Piaro from Philippines. Dr. Christian graduated from University of Philippines and College of Medicine 1999. Upon completion of his degree, he trained for general surgery in 2004 at Philippines General Hospital, where he has completed his residency in training and fellowship program in plastic and reconstructive surgery in 2007. Dr. Aro is a board-certified plastic surgeon, and he has completed his diplomatic Philippine Association of Plastic Reconstructive and Aesthetic Surgeons and is a fellow of Philippine Association of Plastic Reconstructive and Aesthetic Surgeons. So I welcome both the trainers. to this training. And I'm sure, at the end of the day, you will find they will add a lot of value to the program. It's also my pleasure to introduce today's trainee who are, from a different, who are the eminent doctors from the different part of the country. So I will start with North, and our first trainee is Dr. Sunita Kaushik, who's a plastic surgeon with more than 29 years of clinical experience, specialization in aesthetic, constructive and reconstructive surgery, and practices at Northex Cosmetic Surgery Clinic, Delhi. Our next doctor attending today is Dr. Vijay Kakkad. He's a plastic surgeon with more than 28 years of clinical experience, specialization in aesthetic reconstructive surgery and hair transplant, practices in Kakkad Healthcare, Janakpuri. Then we have Dr. Charanjeev Chhabra from Delhi, MD dermatologist with more than 25 years of clinical experience, specializes in injectable cosmetology and laser medicine. She's a medical director of Alive Wellness chain of clinics in North India. Our next attendee today is Dr. Gulima Arora, dermatologist with more than 17 years of clinical experience, specializes in anti-aging medicine, laser and cosmetology, practices at Mahta Gul Derma Clinic, Delhi. Our next trainee doctor for today is Dr. Manju Keshri, dermatologist with more than 22 years of clinical experience, specialized in both dermatology and cosmetology, and practices at Camps Clinic, Vaishali, Ghaziabad. Our next doctor attending training today is Dr. Tapeshwar Sehgal, plastic surgeon with more than 22 years of experience, specialization in aesthetic and reconstructive surgery and hair transplant, and practice it at Aura Aesthetic, Delhi. Then we have doctors from Mumbai, a very senior doctor, Dr. Srilata Trasi, dermatologist with more than 42 years of clinical experience, specialization in cosmetic dermatology and laser medicine. Dr. Trasi is the head of La Pale Skin, Hair and Laser Clinic and is practicing at Khar Andheri, Mumbai. We have Dr. Anju Mathil, dermatologist with 27 years of clinical experience, specialization in anti-aging medicine and cosmetic dermatology. She practices in Skin and Shape Clinic, Lokhandwala Circle, Mumbai. Then we have Dr. Ismail Sheikh, MD dermatologist with 23 years of clinical experience, specialization in Botox, fillers, and thread lifts. Practices at Dr. Ismail Sheikh's Kolaba Skin and Laser Clinic. We have Dr. Sharmila Nayak from Mumbai, dermatologist with more than 23 years of clinical experience, specialization in cosmetology, anti-aging, facial sculpting, and contouring, and practices at the Skin First Clinic near Lokhandwala, Mumbai. We have Dr. Mahima Jain, dermatologist with more than 15 years of experience in clinical dermatology and aesthetic dermatology, specialization in dermatosurgery, trichology, and cosmetology, and practices at Skin Clinic, Mumbai. We have Dr. Batul Patel with us, dermatologist with more than 14 years of clinical experience, specialization in cosmetic dermatology and hair transplant, practices at Bombay Skin Clinic near Chowpatty, Mumbai. We have Dr. Deepthi Gai from Mumbai, dermatologist with more than 9 years of experience, specialized in both clinical as well as cosmetic dermatology, and practices at Dr. Deepthi Gai's Advanced Dermatology Clinic, Mumbai. We have Dr. Rohan Anand, dermatologist with 9 years of experience, specialized in dermatology, cosmetology, aesthetics, and hair transplant, practices in Skin World Clinic, Pune. Then we have Dr. Purva Shah, again from Pune. She's a dermatologist with more than 9 years of experience and specialization in both clinical dermatology, cosmetology and aesthetics, and practices in Derma Center, Pune. We have Dr. Venkataramana, plastic surgeon with 25 years of clinical experience, specialization in aesthetic, constructive and reconstructive surgery, practices at Counters Plastic and Aesthetic Surgery Center, Hyderabad. We have Dr. S.K. Selva Prabhu, dermatologist with 23 years of clinical experience, specialization in cosmetic dermatology and trichology, practices at Zoyan Aesthetic Skin and Hair Clinic, Chennai. We have Dr. Chandan Ashokan, again dermatologist from Chennai with 21 years of experience, specialization in laser, mesotherapy, Botox and filler, and practices at Anaya Skin Clinic, Chennai. We have Dr. Sudha Vani D, dermatologist with 21 years of clinical experience. She is a dermatologist, cosmetologist, and aesthetic dermatologist, and practices at Shri Skin and Cosmetology Center, Hyderabad. We have Dr. U.R. Dhanalakshmi, dermatologist with more than 19 years of clinical experience, specialization in skin rash and other cosmetics and aesthetic procedures. She practices at Dr. U.R. Dhanalakshmi's Skin Clinic, Chennai. We have Dr. Dinesh Kumar, dermatologist with 18 years of clinical experience, specialization in cosmetic and procedural dermatology, practices at Dr. Dinesh Skin and Hair Clinic at Ananagar and Mahalingapuram, Chennai. We have Dr. P. Usha, dermatologist with 17 years of clinical experience. She is a dermatologist, cosmetologist, and aesthetic dermatologist, practices in Samanvi Skin Clinic, Hyderabad. We have Dr. Senthil Shiva Prakasham, dermatologist with 16 years of clinical experience, specialization in aesthetic dermatology, and practices in Radiant Skin and Hair Care Clinic, Chennai. We have Dr. Veena Abraham, dermatologist with 15 years of experience, specialization in scar treatment, Botox and fillers, practices at Abraham Skin and Hair Clinic, Bangalore. We have Dr. Annie Flora, dermatologist with 19 years of clinical experience, specialization in cosmetic as well as aesthetic, dermatology, and practices at Apollo Spectra Hospital, Chennai. We have Dr. K.R. Sharmatha, dermatologist with 12 years of experience, specialization in aesthetic dermatology, and practices at Invent You Face Skin Clinic, Chennai. We have Dr. Devi Priya, dermatologist with 8 years of clinical experience, specialization in cosmetic dermatology and all aesthetic procedures, and practices at Surya Hospital, Sali Gramam, Chennai. We have Celia Matthew, dermatologist with 11 years of clinical experience, again specializes in cosmetology and trichology, and practices at Kaya Skin Clinic, Ernakulam. So I thank you all for attending today's training, and I will request Dr. Fandaro to take the proceedings of today's training forward. Over to you, Dr. Fandaro.
Okay. Good morning. No, sorry. Good evening or good afternoon to everybody. It's absolutely a pleasure to be here. And of course, this is not a course, because this is a training for expert doctor. So we ask you to share your opinion, and if you have some questions and comments or new idea to propose, here we are to exchange our opinion. And so I ask you to use the chat if you have some comment or question. And I start to describe the characteristic based on some scientific study of Definisse thread. And so let me check. I have to share my screen, and then we can start. Okay. So Okay, very good. So, first of all, is absolutely important to well understand that we are not speaking about only one specific type of thread, but Menarini and Relife propose several different types of thread. We have, in fact, the free floating, and later Dr. Aro will present you how use this specific type of thread. Then we have the double needle. Double needle is probably my favorite thread in this white portfolio. And then we have the anchored thread that we can define as the more surgical thread. It has a fantastic lifting effect. And then we have other types of thread, like as the nose or boca and so on. So about the double needle threads, the structures of this specific thread is the following. We have two needles at the extremities of the thread, and we have two different lengths and types of double needles thread. We have a 12 centimeter and 23 centimeter thread, and both this type has a central part without barbs and a middle part with barbs. And of course, in 12 centimeter type, we have 6 centimeter in each part. And in 23 centimeter type, we have 12.5 centimeter in each part. And finally, we have a lateral part without barbs. The copolymer that constitute this specific type of thread is lactide co-caprolactam. So it's a combination of two different polymers. And the combination of two different polymers determine mainly the main characteristic of this thread, that is the double action. In fact, this thread has a lifting action for the support and repositioning of the tissue. And of course, this action is due to the mechanical action. But we have also a second action, that is the revitalizing action, due to the fibrosis that appear along and around the thread after the insertion. But the onset of these two different actions is not the same. Of course, we have an immediate lifting action, mechanical action, and then we have a delayed revitalizing action. And the combination of these two different actions and the different onset and that these two actions has determine the long-lasting result. In fact, first we have a good mechanical repositioning of soft tissue that after few months starts to reduce, and then we have the onset of the fibrosis around the thread that contribute to maintain for a long time the repositioning of soft tissue. And we have several studies and papers that describe this mechanism of action. And in this study, Savoia states that Definisse has these two different effects, the immediate lifting and the delayed revitalizing effect. And in fact, thanks to histological evaluation, they found that around the thread, we have a capsule of fibrotic tissue, and moreover, they noted also an increasing of the thickness of the papilla of the dermis and a neovascularization at the level again of the dermis along the pathway of the thread. And also by ultrasound, they was able to show the fibrotic reaction around the thread, as you can see in this slide. And in this study, Savoia treated 37 patients with different types of threads. Someone with anchorage, other with free floating, but the main part with double needle. And it's very interesting to evaluate the satisfaction that the patient reported. And you can see that satisfaction was good immediately after, but after 6 months, the patient satisfaction increased thanks to the fibrosis around the thread and the biorevitalizing action. In another study by Vincent Wong, again, he performed a histological evaluation after 15 months, and he showed that after 15 months, we have a homogeneous fibrous capsule around the thread. And again, he noted a dermal thickening thanks to the formation of new collagen and elastin. And so again, Vincent Wong stated that we had this histological lifting thanks to the fibrosis around the thread and thanks to the improvement of the quality and of the thickness of the dermis. And in another study by Dr. Kalayan and other, in this study, they evaluated mainly the satisfaction of the patient. And again, you can see here that the global improvement in static score showed a good and you can see that the main part of the patient evaluated the improvement as a very improved or exceptionally improvement. So it's very important also to well understand the distribution of the barbs. Definisse double needle thread has a bidirectional convergent barbs distribution. And so is this type, the first one. And of course, in some thread as Boca, you have a bidirectional divergent distribution, or for example, in anchorage thread, you have a unidirectional distribution of the barbs. But in double needle, we have a convergent distribution. And this, this determine that the final effect we have after the insertion is the accumulation of soft tissue toward the central part. And then we will see why this specific final effect that we reach is fundamental to plan the correct insertion pattern. And another characteristic of Definisse threads is the J-stitch. The J-stitch is simply an angle that we create and this determine a reinforce of the anchoring and support capacity of the thread. And especially in some technique, we can perform this specific technique, the J-stitch technique, to increase the anchoring capacity. And if we compare different types of threads, for example, the Silhouette Soft, Aptos, Miracle Forte, and of course the Definisse thread, we can note that the physical characteristics of this thread are not the same, and each of thread has a specific physical characteristic. Analyze the physical characteristic of each of these threads. We perform the tensile strength test, and this test is able to measure the mechanical strength of the test. And here you see the result of this this test, and here you can see that the Definisse thread 23 and 12 centimeter has an intermediate strength, superior to Aptos and to Silhouette Soft thread. Miracle Forte has a higher strength, but of course this is due to the fact that Miracle Forte is thicker than Definisse 23 and 12, and so the increased strength is due to the fact that the gauge, the caliber of this thread is superior compared with the other threads. But it's also important not only know the strength of the thread, but also other two important physical characteristics: elasticity and plasticity. And we can determine these characteristic with creep and recovery test. In fact, if we apply a load for 18 minutes and then we remove the load and we wait for 20 minutes, we can evaluate the elongation and the elasticity, that is the capacity to restore the original length of the thread. And on the other hand, we can also evaluate the plasticity, that is the tendency to maintain a residual elongation. And here you see the creep test results of Definisse thread, and the recovery is around 50%. So we have a good elasticity, but in any case, we have also a good plasticity. And we have a balance between elasticity and plasticity. Concerning the Silhouette Soft, the recovery is absolutely lower, around 11%. So this means that the elasticity of this thread is absolutely low, and it has a higher plasticity. On the other hand, we have the Miracle Forte. Miracle Forte has a high elasticity, around 89%, but of course, a low plasticity. So we can say that if we evaluate the balance between elasticity and plasticity, we can say that Definisse thread has a good balance between these two physical characteristics, and as Aristotle used to say, medio stat virtus, that means that the virtue stands in the middle. The balance between these two characteristics allow a good integration of this thread in soft tissue, a good response to the strength due to the movement of the head or due to the movement of facial muscles, and a good capacity to reposition the soft tissue. Okay, so I finished my first presentation, And I think that if we have no question, and usually we have no question after this this first introduction, if you are agree, we can go ahead with Dr. Aro, that will introduce us some essential anatomy aspects connected with thread. Do we have, Jirzan, do we have
No questions so far, Dr. Fandaro.
okay, as usually, because this part is not probably so
Yeah, so as it goes, it will become more.
The doctors. Okay. Aro, please.
Okay, I'll start.
Thank you.
Wait a minute. Okay, good afternoon, everybody. Thank you for this opportunity to talk about the different threads. We'll give you a background first. I'll give you a background of the anatomy and then how the procedure is done, and then Dr. Fundara and I will also discuss the different techniques that we can use to reshape and lift parts of the face. So today I'll be talking about essentials of facial anatomy for threads. We'll start with the basics, which are the layers of the skin of the face. On the face, we have 5 layers of skin, namely the skin, the subcutaneous layer, the SMAS, the retaining ligaments in space, and the deep fascia or periosteum. Visualizing these layers will help in the proper placement of the threads. Here, on the left side, we have a picture of the SMAS. Of course, the superficial fat compartments have already all been dissected, but we have the SMAS here. This is one of it's a layer that separates deep and the superficial fat compartments in the face. And on the right side, we have a reflected SMAS on the lateral aspect of the face. If you notice, after reflecting the SMAS, there are some structures that we can see underneath. We have your deep temporal fascia, we have temporal branch of the facial nerves, and the parotid gland. Now, on the face, there are different compartments, and they may differ in appearance in the youthful face and in an aging face. As you can see from this diagram, the aging face has some degree of atrophy, and this atrophy of the fat compartments in the face is of course different per individual. Now, in the face, there are superficial and deep fat compartments. In this slide, we see 7 superficial compartments. These are the infraorbital fat, the medial cheek fat here, and the nasolabial fat, which is this one, nasolabial fat, and then the middle cheek fat, the lateral cheek fat, and then your superior and inferior jowls. All of these compartments are superficial to the SMAS. Now, next, we have the deep cheek compartments. We have 4 cheek compartments. These are the medial suborbicularis oculi fat, the lateral suborbicularis oris fat, the deep medial cheek fat, and the buccal fat. Now, in thread lifting, the goal of rejuvenation of the face using barbed sutures is adequate suspension of the superficial tissues. Anatomic considerations of the aging patient will dictate treatment of the patient. In particular, we see prominent aging in the lower face, and this can be, prominent sagging in the lower face, and this can be addressed with several lifting techniques. As we age, we will notice disappearance, thinning, and retraction of the fat pads. So you can see here on the other diagram, the fat pads have already thinned out and retracted. Knowing the position of the fat pads can help in identifying the entry points of the thread, which may give optimal lifting of the sagging tissues. Now, the deep fat compartments are attached to the periosteum and deep to the SMAS. These compartments are quite stable, and there's really no need to reposition this fat. Now, a common fat pad that needs repositioning in patients that we see is the malar fat pad. This is composed of 3 superficial fat compartments, which are the infraorbital fat pad, the medial cheek fat pad, and the nasolabial fat. In these areas, as the septae of the SMAS sags, there is less retaining capacity of the fatty tissues in the cheeks which causes slipping and greater fat protrusion. The barbed sutures that we use are positioned in the subcutaneous tissue above this mass, and their structure permits hooking and lifting of the tissues. Now, we should also take note of the skin thickness around the face. The skin is thicker on the mid to lower areas of the cheek and the chin. Because of this, the depth of the needle should be adjusted as it traverses the different areas of the face. It's also noteworthy that since there's thicker areas, you will have to exert a little more effort in inserting the needle in certain parts of the face. These slides are just different danger areas in the face, and avoiding these areas will minimize possible complications during thread lifting. Now, Definisse thread lifting. This is just the safe operating procedures. In this segment, I shall be discussing the ideal candidates for thread lifting, the patient assessment, and importance of a sterile field. Now, Definisse threads is ideal for patients between the ages of 30 and 60 who show minimal to moderate signs of aging. They should have normal to thick skin with trophic or hypertrophic superficial fat. This, however, is just a guide. It's not a hard and fast rule, the 30 to 60 years old, because I'm sure in all our practices, we've encountered patients, 70-year-old patients that look like they're in their 50s. And once in a while, you find 20-something-year-old patients that look like they're in their 40s. So it's really not a hard and fast rule. It's just a guide. Now, here's a list of the absolute contraindications for happy lift. Of course, these are all important, but personally, I take note of patients that have unrealistic expectations. When you have a patient that has unrealistic expectations, chances are the patient will not be happy with the outcome of the lifting, thread lifting, and also chances are these patients with unrealistic expectations have quite an advanced degree of sagging. So you really will not be able to do much for them. And then the other contraindications are also quite important. They deal with systemic disease, skin diseases, and bleeding disorders. This is a list with the relative contraindications for thread lifting. Now, Definisse thread lifting is a clean procedure. Insertion of threads are usually done in operating theaters and ambulatories. It is imperative that disinfection of the face is done with antiseptic solution. And as much as possible, the surgical field must be devoid of hair and the whole face should be visualized. During the procedure, one must use sterile gauze, gloves, and scissors, and maintaining sterility during the procedure is of utmost importance. The procedure is done under local anesthesia using lidocaine with epinephrine, and it's injected in all the entry and exit points. Infiltration of anesthesia in the intermediate points or in between the entry and exit points may also be done. Now, after surgery, we usually give them a list of things of you can and can't do. This is a list of the post-operative instructions, but basically we can address the pain. We tell the patients that the pain that they may experience can be addressed with paracetamol, and we also give them a short-term antibiotic. And then we also advise them about to avoid excessive movement of the face and neck, and also no eating of hard food, no boisterous laughter. And we also tell them to avoid using makeup as long as possible, usually a minimum of 24 hours. And of course, no high impact sports. Now, prior to procedure, it's important to have planning for the treatment. Now, when we plan for the treatment, we have to first draw our safety lines. We usually use a red pen for this. Red meaning don't cross it. Don't cross the safety lines. And then after we draw the safety lines, we then identify the entry and the exit points depending on the treatment that we're going to do. And lastly, we identify the reshaping lines. Now, Definisse revitalizing threads are designed for facial reshaping. In order to get optimal results, the insertion of the needles have to be in the subcutaneous plane. This is also done to avoid pain and bleeding during insertion and visibility of the thread. As you can see in this diagram, there are 3 levels of the skin on the face, 3 levels. The first level is the skin here. The second level is the subcutaneous tissue. And the third level is this mass. When we insert the thread, when we insert the needle and of course the thread through the tissues or through the face, we want it to be in level 2 or the subcutaneous tissue or the superficial fat compartment. There are minimal blood vessels and nerves in this plane, which makes the insertion relatively painless. This diagram shows how the skin is connected, is attached to the periosteum. This is the periosteum, and just like a tree, the retaining ligaments are thick here near the periosteum, and as it goes further away from the periosteum or from the bone, the ligament divides, and when you reach the retinacular cutis, you have many branches. These branches are actually, if I go back to this picture, these branches are over here. These branches are where we anchor our threads. Now, here again, this picture just shows the plane that you want to be in. You want to be in this plane, the subcutaneous plane, where there's a lot of fatty tissue. And in the retinacular cutis, there's a lot of fibers here that the threads can be anchored upon. This is the skin and this is the mass. Now, knowledge of anatomical modifications related to aging process can guide our choices and suggest which patients may benefit from the treatment and which superficial fat compartments must be treated and lifted. Sorry. This phase is crucial because choosing an inappropriate correction will likely result in a partial or no improvements in the patient's defects. Correct planning will deliver a satisfactory result. And to facilitate the treatment choice, we suggest applying an aging type of classification of the mid-phase. Here we have a classification of a type for aging on the face. On the left side, or the first classification, you have a patient with a hypertrophic face. And on the rightmost side, we have a patient with a hypertrophic ptotic face. In between, you have a combination of number 2 is a hypertrophic ptotic, and number 3 is ptotic hypertrophic. Now, therapeutic approach for these patients are, for the hypertrophic patients or hypertrophic face, therapeutic approach is a volume augmentation, whereas therapeutic approach for hypertrophic ptotic is lifting. In between, you can do a combination of volume augmentation and lifting. Now, for the main treatment for hypertrophic faces is we use a very high G prime filler. And for the hypertrophic ptotic, we use a suspension thread. And once again, in the middle, it's a combination. You can use a filler and a suspension thread. And that's it. That's my part. Dr. Fundaro will now be lecturing on the some of the different techniques that we use in thread lifting. Are there any questions?
Hello.
Yes.
There are some questions. Yeah, go on, Dr. Sudha. So there is a question from Dr. Gulima. What is the duration of biostimulation with Definisse? Fibrosis cannot be controlled. How do you prevent complications from excessive fibrosis if it occurs?
Okay. Sincerely, these threads are on the market in Europe and in other countries since I think they started to be sold in around 15 years ago, and I think that the problem of hyperfibrotic reaction is never has never been described, And this thanks to the fact that the composition between lactide and caprolactone is absolutely well balanced, and the fibrotic reaction usually is controlled. As you will see, in of course, we have to probably avoid the use of this thread in patients with the keloids, because you know that patient with keloids predisposition may have an excessive fibrotic reaction. But sincerely, we never noted such a type of problem. Even also in patients that receive several times this type of a procedure.
Yeah. So one more question is there from Dr. Dinesh. It says, would you advocate injecting LA along with RLS?
Yes, we will describe how to perform the anesthesia during the next presentations.
That's it. No other question.
Okay, so we can go on, and I first describe the DIR technique that is effective and simple technique, and of course now we know the structure of the thread, and as I said, I remember you that the final result is an accumulation of soft tissue towards the center part of the thread. This is an important point, because we have to keep in mind that where we will locate the center part of the thread, there we will have the main accumulation of soft tissue. So in some specific type of phase, in some specific type of patient with a specific anatomical characteristic, the accumulation in a specific part of the face could be a positive effect, but in other patients, sometimes the accumulation in the same part is not a good result. So we have to evaluate the shape of the face, the dimension of the face, the characteristic of a distribution of soft tissue, especially of superficial soft tissue, and based on this assessment, we can evaluate the best type of technique we can use in each patient. Another important point is that we have a tissue that is repositioned, and in this case, these tissue are the superficial fat compartments. But we have also other anatomical structure that act as the anchoring structures, and in this case are the ligaments of the face. Here you see the superficial fat compartment of the face. Dr. Aro already described this fat compartment, and it's important to remember the anatomy of this fat compartment, because we have to have a good knowledge of this anatomy to plan an adequate technique and insertion pattern. Again, it's very important also remember that we insert the thread between the skin and the SMAS plane. In this space, we have a superficial fat compartment, but we have also the retinacular cutis. And retinacular cutis are the ligamentous structure that assure the good interaction between the barbs of the thread and the surrounding tissue. So, patient with thicker retinacular cutis and stronger SMAS system probably have a higher repositioning compared with a patient with a not so strong fibrotic structure of the SMAS system. And for example, usually Asian people has a stronger SMAS than Caucasian patients, and probably for this reason we have different results, and also the duration of the results are longer in Asian people than in Caucasians. And again, it's very important also remember the anatomy of anchoring ligaments. And here you see the main anchoring ligament. And in JR technique, in jawline reshaping technique, we will use specific specific ligament that I will describe after. And here you can see that in all the techniques we have a part of the thread that works as the anchoring part in red, and the repositioning part is the blue line that you see here. And in these three different techniques that are the jawline reshaping, malar reshaping, and lateral reshaping, you see that the vector, repositioning vector, is more lateral. And in other techniques as over reshaping vertical and over reshaping H, again, we have the red part that act as the anchoring part, the blue lines that represent the repositioning part of the thread. And here you see that in these two techniques, we have a more vertical repositioning vectors. Again, very important, remember that these are sterile procedures. And so we need surgical drapes, gauze, scissor, surgical gloves, needle, and we have to prepare, set up a small surgical field. So we need to disinfect all the surface of the skin, as you can see. And I recommend to continue to disinfect the skin during the procedure, because the sterility in this technique is absolutely very, very important to avoid the infection. So this is the jawline reshaping technique, and the repositioned tissue are the superficial fat compartments along the jawline. And as Aro described, we have several layers, but here you see that the fat compartment that we reposition with the JR technique are the superior and inferior jaw fat, and the inferior part of the lateral cheek fat and middle cheek fat. And here you can see that it's possible to dissect the superficial fat compartment and expose the SMAS plane of the cheek. Here you see the SMAS plane, and finally here you see the zygomatic major muscle. So the SMAS plane is the forbidden limit, because we cannot insert the needle and the thread underneath this specific anatomical layer, because under the SMAS plane we have the vessels and the nerves and other structures as parotid glands, Stensen's duct, and so on. So it's very important to respect this plane and insert the thread only into the superficial fat compartments. And here you see that if we remove the superficial fat compartment, we can identify the deep fat compartment that are the medial lateral sheath and the medial cheek fat, And here you see that we can identify also a lateral and a medial part of this specific fat compartment. And here you see the Stenson duct under the mass, or here you see the branches of facial nerve, again, underneath the mass. So very important, and you can well understand why we have to avoid the insertion under this specific anatomical layer. And the anchoring tissue. The anchoring tissue that we use in the JR are specific ligaments. We well know what is a ligament. It's a fibrotic structure that support and maintain in a fixed position the soft tissue of the face. The true ligament runs from the periosteum and reaches the dermis. And we have several facial ligaments, but in JR technique, we use mainly the platysma-auricular fascia, that is a fibrotic attachment in the preauricular area, and the platysma-auricular ligament, that is again a fibrotic ligament that connect the lateral borders of the platysma with the ear cartilage. And now we know the anatomical structures that we reposition, we know the ligament that we use, and it's important to plan the technique in order to use the ligament, the proper ligament, and in order to reposition the specific fat compartment. And usually we use a Definisse 12 centimeter double needle threads. This technique is quite simple. First of all, we have to identify the two safety lines, safety line 1 and 2, and these two lines identify the dangerous area, because the area beyond this this line has an increased risk of vessel damage. In fact, you can see that cranial to the safety line 1, we have the temporal, superficial temporal artery and vein, and medial to the safety line 2, we have the facial artery and the angular artery. So for beginner, we suggest to not insert the thread beyond this line, and for expert doctor, we suggest that they can insert the thread and the needle beyond this line, but they have to respect absolutely the correct insertion plane. And this is the insertion pattern of July reshaping technique. We start creating the first entry point here. This point is posterior to the angle of the mandible, because posteriorly to the angle of the mandible, we have the platysma auricular ligament. So we use this ligament as anchoring point. Then we insert the first needle, reaching the exit point along the jawline, and we insert the first part of the thread. After we insert the second needle again through the same entry point, this one, and we insert it reaching the intermediate point in pre-tragal area. Then we pull out the needle, we insert the second part of the thread, and then we introduce again the needle through the end point, and we reach the exit point too. And in this way, we perform the J-stitch technique that increase the strength of the anchoring action of the thread. And here you see the ligaments that we use to reposition
Hello, Dr. Fandaro.
I think we lost him. Let me just call him, Sanjay.
Yeah. So meanwhile, doctors will request you to keep on posting your questions. After end of the session, we will be taking up these questions. Keep on posting the questions on the chat box. Unmute yourself, sir. Dr. Fandaro, please unmute. Dr. Fandaro, please unmute.
I think he's not able to hear us. Let me call him.
Just call him on the phone.
I had a problem with my connection, sorry.
Yeah, no worries. Now it's audible.
Yes, but where started the issue?
Just, few
You can
slides
present
back.
your slides. We can tell you where it is.
Okay, so sorry, but I have some problem with my internet connection. Lateral shaping layer. Let me see where are the. Okay, here.
We completed till the J stitch.
J stitch. I was
Yeah.
okay. So I think here.
Yes. Yeah. Here you could start off. That's right.
Okay. So sorry.
No worries.
Okay. So here you see the fat compartments that we reposition: superior, inferior jaw fat, and the lower part of the middle and lateral cheek fat. This is the lateral vector that we use to reposition the soft tissue. And remember that in this technique, we have an accumulation, especially close to the angle of the mandible. So in patient with a wide mandible is not a good technique. Is not indicated for this specific type of patient. And here you see the J stitch. Remember that when we create an angle, we increase the holding strength of the thread. And for this reason, we perform the J stitch in the caudal part of the thread, and because we want to increase the anchoring capacity. So I show you the video of JR technique. So you see that we can mark the safety line, the entry point, the exit point, that in this case is always lateral to the marionette line, the exit point, intermediate point, and finally the exit point 2. We can also mark the reshaping line, and for beginner it's very important to mark these points and these lines, because they facilitate the thread insertion and facilitate the injection of local anesthesia. After this, we can start with the infiltration of local anesthesia. You can inject only in the entry and exit point, or if you want, you can inject also along the reshaping line. After this, we create the entry point with an 18 gauge needle. The adrenaline inside the local anesthesia determine the vasoconstriction and reduce the bleeding. And in fact, usually we have no bleeding during the insertion, and also the bruising are not so frequent. So you see that the insertion of the needle is done step by step, checking the correct insertion plane, and slowly we reach the exit point. And now, using the cap of the needle, we try to create the exit point in a perpendicular direction respect the dermis. This is important because in this way we reduce the dimpling of the skin at the level of the exit point. Then we insert all the first part of the thread, and we then we can insert the second needle through the same entry point. And it's very important to be sure that we use the same hole we created with 18 gauge when we insert also the second needle, because again, in this way, we can reduce the dimpling at the level of the insertion point. Then again, we insert, checking the correct plane, the needle, and we reach the intermediate point. We pull out the needle now, and we can insert all the second part of the thread. As you can see, we check if we don't create a loop at the level of the thread. And finally, we can insert again the needle through the intermediate point and reach finally the exit point, the second exit point. Again, we try to pass through the dermis in a perpendicular way using the cap and of the needle, and the cap of the needle helps also to protect our fingers and the skin of the patient. And here you see the J stitch that start to work, and now we have only to reposition in without overcorrection the soft tissue. We can pull the thread, and you see that pulling the thread will increase the anchoring capacity of the especially at the level of the J stitch. And finally, we have to cut, and if we need, we can apply a slight pressure on the exit point to unhooking the barbs that can be engaged with the dermis. And so you see that this technique is quite simple. You spend no more than 20 minutes to perform this technique in both sides of the effect, and the final result usually is absolutely well appreciated by the doctor, by the patient. Okay, do we have some?
Yeah, we have some questions. So one question is, how are bidirectional barb threads superior to multi-directional threads?
Okay. The difference between these two threads is basically on the mechanism of action, because the bidirectional convergent barbed thread as Definisse use specific white part of the face as anchoring point, and using this anchoring area are able to repositioning specific part of the face. The multi-directional barbed threads are able to create micro compactation of small part of the face. So the result is absolutely different at the end, because they don't work using an anchoring part and repositioning specific area, but they create small area where the tissue is compacted and create a more distributed lifting effect. But of course, the distance that they can determine, the repositioning that they can determine, in my opinion, is lower. Aro, do you have experience with multi-directional barber threads?
No, I haven't used those threads, but as you said, it works totally different. I mean, the concept is totally different. It will make micro compactations, whereas if you have a double needle thread, sorry, a bidirectional thread, as you said, the line here is for the reshaping, and the line here is really for anchoring. And if you put a J, you have an even stronger anchor, because basically, since the threads are going this way, the barbs are going this way, with time and weight, it's going, the soft tissue is going to go downwards and push the thread out. But since you have the converging threads on the other side, it's going to prevent that from happening. I don't think that's going to happen with the multi-directional threads.
Yeah.
So another question is how long the effect of thread lasts. I mean, if we're doing a lifting in a patient, how long will that effect last?
Okay, so we are planning a study in collaboration, of course, with Menarini and Life, and probably within 1 year, I will be able to give you an answer. I can only say that usually my patients request a new treatment with thread after 8 months, 1 year. And I think that it's important also to consider that the duration is not the same if we compare different ethnical groups. And usually we noted a long-lasting result in Asian patients, and the duration is shorter in a Caucasian patient. So I think that the characteristic of Indian people is in the middle between Asia and Caucasian. So probably in India, you will have a longer duration comparing with Caucasian. But usually I treat, I perform the second treatment after 1 year. And usually I use only 1 thread per side. So if you increase the number of thread per side, you increase the repositioning effect, but also the duration. And Aro, in your experience, how long?
Yes, more or less the patients would request, if if they request, if they usually come back anywhere from 10 to 12 months. But often actually you see the patients on those times, they really just come and say, should I have it done already? Because I tell them that in 12 months, chances are the threads, the lifting won't be as evident anymore after 12 months. But when they come, it's really a matter of, are you still happy? Because if you're happy with the results, maybe we don't have to do it right now. But if you feel that it's already gone down, okay, we'll do it again. But if you feel it's still okay, there's really no need to do it on the exactly after 12 months or 10 months.
Absolutely.
Yeah. Now another question is, how will you know that you are in smash plane, and can you lift smash with these threads?
Okay. Okay, I think that it's quite dangerous to try to lift smash because it's difficult, very difficult to control the depth of the thread, especially when you try to inject the lower part of the deeper part of the layers. And so I suggest to stay and to insert the thread in the subcutaneous tissue, and I think that you have an higher holding between the barbs and surrounding tissue if you insert the thread more superficially close to the dermis, because close to the dermis the thickness of retinacular scuti is higher, so you have a very thick network of fibrotic tissue near the dermis, and a loose network, fibrotic network close to the mass. So if you want to create a strong interaction between the thread and the surrounding tissue, you have to insert the thread more superficially. Of course, first you have to check the thickness of the skin, because Arrow said that we have different thickness of the skin in different area. Usually Indians, and I think also Asians, has thicker skin compared with Caucasian. So probably you can insert the thread slightly more superficial, because the risk of palpability or visibility of the thread in patient with thick skin is low. So I think that is not a good idea to try to lift this mass. And you can understand if you are close to this mass or deep to this mass, if the patient has pain, because pain is a sign that you are too deep, you are too close to this mass. And for this reason, a lot of doctors usually don't perform local anesthesia along the reshaping line, but only at the level of the exit and entry point. And I think that Dr. Arrow usually do this type of anesthesia for this specific reason.
So another question is almost similar, like Dr. Chiranjeev Chabra says, what will happen if you insert muscle in the muscle layer by mistake? While
bleeding. Probably you have more bleeding, and you can add also permanent pain due to the traction that the muscle movements determine on the threads.
If you're lucky, it's just the bleeding and pain. If you're lucky, if you're not lucky, you might hit you might hit the stenson duct, the parotid gland, you might get a sialocele, or you might hit a nerve. So you don't want to do that.
Yes, I think that is very important to respect the superficial insertion plane. Absolutely, because every time that I tried to go deeper, because I was curious to see if I can reach different and better results, or always I have some trouble. So I suggest you to don't try again.
Then there is one question from Dr. Batul. For the GR technique, if you have done fillers in pre-tragus area, can you still do the GR technique? Will it cause accumulation of the filler?
No, I think that if you have done filler injection in the pretragal area, you have no problem. And of course, in this case, you have to wait minimal 15 days between filler injection and thread insertion.
We have one question from Dr. Dinesh. For JR endpoint, should be how many centimeter/millimeter anterior to tragus?
The intermediate point. Okay, so the threads runs from the entry point and reach the pretragular area. And you can stay usually few millimeters anterior to the first wrinkle that usually we have along the pretragal area.
So there's one question
I
from, yeah.
I usually just do 1 centimeter.
Sorry?
I usually just do 1 centimeter
1
in front of the
centimeter
tragus.
yeah.
So there's one question from Dr. Gulima asking about the size of needle and thread and the gauge.
Okay, I forgot.
And is it a sharp needle or a needle cannula also?
Okay, so the thread gauge is 2-0, and sincerely I don't remember the gauge of the needle, but surely the needle in 23 centimeter type is absolutely thicker than and longer, is longer 15 centimeter. And the needle that we have in 12 centimeter type is thinner and 10 centimeter long. And they are sharp needle. They are not cannula because we have to create the exit point and we need a needle to pinch the, to pierce the skin. And I think that the sharp point of the needle help us to control the insertion level. Because if you have a weak needle with no sharp point, sometimes the needle can go
Zigzag.
more superficial because you cannot control exactly the insertion. I think that Aro, you are agree in
Yes.
point
If it's rounded, you really can't tell where it's gonna go.
yeah,
Because if there's something hard in front of it, it's just gonna avoid it. But if it's sharp, it's gonna go through.
exactly, and
I think
you can also penetrate the ligaments that we use as anchoring point.
I think the 12 cm needle is about more or less it's a gauge 20, and
Yeah.
the 23 cm needle is, I think, a gauge 19.
Okay, thank you.
The needle.
Yeah, the needle, absolutely.
So there's one question from Dr. Dinesh. He says, the Silhouette soft needle has a mark where the direction is to be changed from perpendicular to under the skin. Does Definisse needle have a similar mark?
No, the reason this mark. Okay, it could be useful, but I think that if a doctor needs this mark to understand if he is in the right position, means that this doctor is not so expert. Okay, so I think that it could be useful only for beginner, but believe me, after a few treatment, absolutely you don't need this mark.
Then there's a question from Dr. Batul. Which are the patients which fit for JR technique?
Sorry?
Which patients are fit for JR technique?
Ah, yes. In Caucasian patient, especially patient with jowl defect, okay, and patients that want a straight jawline and increase the definition of the angle of a mandible. And usually I use this technique for these indications.
So then there is a question from Dr. Gulima. There is a smooth part of thread in the middle. If this part comes in lifting vector for JR, won't it compromise on the result as there is no barb?
No, we have this center part without barbs because we want to be sure that all the thread at
Goes
the
in.
level of entry point is buried under the skin. If we have barb in the central part, we can hook the dermis and we can create a dimpling of the skin. The unbarbed central part avoid this problem.
Uh, can I just speak something, Mr. Bhan?
Yeah, please.
Yeah, so actually, doctor, my question is not that. If you're not measuring the entry and the exit points, you have shorter jaws in some patients and longer jaws in others. If you're not measuring it, it's not necessary that the smooth middle part would come, near your entry point. So that's what I wanted to know. I mean, how do you decide without measuring that, the smooth part is actually in the center of the thread? It could go onto any vector as well.
Okay, but you can check directly where is the central part and
Yes,
during
so
the
then you'll have to
inspection.
pull out the thread that much more from the exit point, I guess, to make sure that the smooth part is near the entry point. Am I right?
Yes,
Yes.
exactly.
Thank you.
Exactly.
Then there is one question from Dr. Trasi. After how long, when you do threads, you can do any other aesthetic treatment?
Aro,
It depends on which treatment you're planning to do. If you're just planning to do like volume augmentation or Botox, you can probably do it after 2 weeks. Or if you want to do the fillers first or the Botox, you can do that first and then do the threads after 2 weeks. But if you're going to use an energy-based device, I suggest you do it. There should be a 2-month interval. If you do the threads, you can do the energy-based 2 months after, or if you do an energy-based device first, you can only do the threads 2 months after you do the device. Don't do it anytime sooner. You won't have the optimal results.
Then there's one question from Dr. Dinesh. How easy is doing threads for patient who has multiple thread sessions in past with resultant fibrosis? Any tips?
Sincerely, I didn't know the fibrosis that can create any problem for insertion in patients that received previously the threads. Different is for patients that had facelifting, because in that case, anatomy is absolutely modified, and take care because also the thickness of subcutaneous tissue, especially in the area of facelifting dissection, is absolutely reduced. And so the risk to go under this mass is higher. And also pay attention in patients that had a permanent filler. And patients with permanent filler, first of all, are not indicated for thread insertion because risk of the infection of permanent filler is absolutely high, and this can create a lot of problem. And this patient has a huge fibrotic soft tissue, and so I think that again the insertion is absolutely very complicated. Yeah.
So another question is from Dr. Manju Keshri. What can we do if a patient complains of persistent pain after procedure? What could be the reasons?
We will explain later
Later
with
session.
the complication section.
Yeah, I think one last question, we can take other questions after next session is, when you talk of Asian patients, are you talking of Chinese or Korean? The Indian facial shape would be different.
Absolutely yes. Absolutely yes. I think that concerning the shape of the face shape of the Indian, they are probably more similar to Caucasian than Asian. I think that they are in the middle, okay? but absolutely they are not the same comparing with Chinese or Korean.
So I think we will take, there's one more question. Do you recommend to wear face pressure garment after the procedure? If yes, for how long?
Okay, it would be a great idea, because especially if you combine thread with endo laser, as often I do, we can propose a pressure garment after the procedure, but sincerely, few patients accept this post-treatment medication. And so sometimes I apply some steri strip that the patient will remove, I think, immediately after they get out my clinic. And because in my experience, patient don't want have steri strips or other garments on the face, and they won't start immediately their normal life. So it could be a good idea if patient accept. We can propose this strategy, but my experience, a lot of patients don't want this type of post-treatment period.
So we can go to next session, Dr.
Yeah.
Fandaro.
Yes. Okay, next section is about matter reshaping. Okay, let me see. Okay. So this is the matter reshaping technique. As we can well understand, we reposition mainly the soft tissue superficial fat compartments of malar area. And the fat compartments that we reposition are the infraorbital, medial cheek fat, and nasolabial fat. Usually these three fat compartments compose the malar fat pad. And these are the three fat compartments that create the malar fat pad. This is the infraorbital fat, immediately inferior to the inferior orbital rim. Laterally to the nasolabial fold, we have the nasolabial fat, and between these two fat compartments, we have the medial cheek fat. This fat compartment lay on the SMAS plane, and here, in fact, you can see that under this plane we have the orbicularis oculi muscle that indicate the SMAS plane. Okay, we can skip. Okay, so the anchoring tissue in malar technique are the platysmauricular fascia, the McGregor patch, and here you can see the McGregor patch. This is the zygomatic cutaneous ligament, McGregor patch, and then we have the masseter cutaneous ligament along the anterior margin of masseter muscle. And another very important ligament that we use in this technique is the zygomatic cutaneous ligament. So we can perform this technique using a 12 centimeter or a 23 centimeter double needle based on the dimension of the face. And of course, patient with a big face probably need sometimes a 23 centimeter double needle thread. Again, we have to mark the safety line as in all techniques that we perform, and then we plan the entry point and the exit point in the reshaping line. You see that the entry point is in pretragal area, and the two exit points are close to the safety line 2, quite close to the nasolabial fold. And the position of exit points is fundamental to determine different repositioning effect. If we maintain quite close one to each other, these 2 points, we concentrate the repositioning at the level of the malar fat pad, and so we can reduce the depth of the nasolabial fold. But if we move the exit point 2 out to in a more cranial, more caudal position, we can also reposition the superior jowl fat, and in this way we reduce the marionette line. So based on the characteristic of the face of each patient, we can modify the position of exit points, but we can also, as we will see, modify also the position of entry point. You see here the ligament that we use if we put the entry point caudal to the safety line. We use mainly the McGregor patch and platysmal auricular fascia, but we can also move cranially the safety line, the entry point. And in this case, you see that we will use also the zygomatic ligament as an anchoring point. And moving the entry point cranial to safety line, we modify the vectors, because in this case we use a more vertical vector, and so we determine a different repositioning of malar fat pad. Again, the patient's characteristic will determine the position of entry point and the vector that we want to use. The soft tissues that we reposition are the nasolabial fat, the superficial medial cheek fat, the infraorbital fat, but also the middle cheek fat, and as you can see, also the superior jowl fat. And here you see the technique, the video that shows this technique. We create again the entry point with the 18 gauge needle in a perpendicular way, and then we insert through the hole that we created the first needle. And again, it's very important to insert the needle slowly, and if we need, we can pinch the skin, as I'm doing here, to increase the space between dermis and the SMAS plane, and in this way it's easier to insert the needle in the correct plane. And after this, we pull out the needle, we insert the first part of the thread. So in this way, you can check also if the central part without bar is at the level of the entry point. You can do this simple maneuver, and in this way, you are sure the central part is at the level of the entry point. And we introduce the second needle through the same entry point. Again, pinching the skin, we can control the insertion plane. Especially, we can also manage the convexity of the cheekbone, and moving and pinching in a different way the skin, we can maintain easily the good insertion plane. Then we cut the two needles, and finally we have only to reposition with this maneuver the soft tissue of malar fat pad, and you see how the nasolabial fold improved and the lifting repositioning effect. And finally, we cut the external part of the thread, and if we have dimpling, a slight pressure eliminate this this dimpling, and you see the final result, natural, quite natural. And if you want, you can apply study strip in this way, or if patient doesn't accept the study strip that can help us to maintain a good repositioning, we simply cover the entry and exit point with small pieces of study strip in this way. Okay, so I think that here you can see some cases. Here you see the insertion pattern, the superficial fat compartment we reposition, and this is the result after 1 month. You can see we have a good improvement, a good repositioning, and you can see also that also the fastness improves a lot thanks to the natural repositioning of soft tissue of this area. And also in this patient, you can see the improvement of the volume of the cheekbone, simply using the volume that the patient has in this specific area. We simply reposition the volume in a natural and correct position. Okay, so I think that we can go on, and then we will do we will do the question time after my second presentation. Are you agree?
Yeah, doctor, let's do that.
Okay, so we can go ahead and describe the lateral reshaping technique. Lateral reshaping technique, again, you can see we have an anchoring area and a repositioning part of the thread. And again, it's very important to well understand the anatomical structures that are involved in this technique. We reposition the superficial fat compartment of malar fat pad and the superficial fat compartment of the jawline. So we act in 2 different parts of the face using only 1 needle. And so you see that we have several fat compartments involved in this technique: the malar fat pad, the middle cheek fat, lateral cheek fat, inferior jaw fat, and so on. So usually we use a 23 centimeter Definisse double needle thread, and we plan the entry point in the pretragal area. Okay, you see that we are quite close to the superficial temporal artery, so it's very important to control the depth of insertion, especially when we insert through the entry point, the tip of the needle. And then we reach with the needle the intermediate point, again slightly posterior to the angle of the mandible, to use the platysma auricular ligament as an anchoring point. Then we introduce again the needle through this intermediate point, and we reach the exit point 1 that is lateral to the marionette line. And then we insert the second needle, we reach the exit point 2, and then we insert the second part of the thread. So in this technique, we use 4 different ligaments as anchoring structures, and we are able to reposition in the main part of the fat compartments of the cheek, as you can see. So I think that this technique is absolutely a technique that allows us to reach good result using 1 single thread. Of course, this technique is indicated in patient with a oblong face and is not indicated in a patient that has a round face, because we cannot increase the width of the face in a patient with a large face. So it's indicated mainly in Caucasian patient and probably less in Asian patient. And again, for Indian patient, we have to evaluate the characteristic of a face and evaluate if this technique is good for them. So now I show you the technique. Of course, it's very important to check the quality of the skin, the thickness of subcutaneous tissue, and and here you can see, you can also try to evaluate the final result that we can reach pulling the skin in this way, and in this way we can show the result of the procedure to the patient when we explain to the patient the technique. So again, we mark the entry-exit point, and in this case, you will see a variant of this technique because we insert the thread also at the level of the submental area to eliminate the platysma bands in submental area, and this is the final exit point. This is, of course, a variant of this technique. So then we plan the exit point here, close to the nasolabial fold, and we can mark, of course, the reshaping line as usually, and the safety line in red. So injection of lidocaine with epinephrine at the level of entry point, and if you want, also along the reshaping line. Then disinfection, very important. Disinfect also the air, disinfect all the face of the patient, and apply the surgical drape, and then we can start to insert through the entry point we created with the 10-gauge needle the first needle. You see, now I'm using a 23 centimeter thread, and you can see that the needle is absolutely thicker and longer than the needle we have in the 12 centimeter thread. So we reach the intermediate point here, and we create the intermediate point. We can enlarge this entry point using the 18-gauge needle as you saw. And after this, we pull out the needle and we insert the first part of threads. And now we have to insert again the same needle through the intermediate entry point, and now we insert the needle along the jawline, and we reach the inferior jowl fat here with the tip of the needle, and now we can change the direction of insertion. Okay, you see that if you have some doubts about the depth of insertion, you can pinch the skin, and this facilitates the control of the insertion depth. And when you reach the jowl fat compartment, you can continue to insert the needle. In this way, you see I change the direction and I reach the final exit point, and then I can pull out the needle and insert all the first part of thread. Okay, so in this way, we reduce the platysma band in the upper part of the neck. And now we insert through the entry point the second needle, and we reach the exit point here. And finally, we insert all the second part of the thread, and we have to check that no hair are inserted with the thread. This is quite important, but we have to spend only a few seconds to check this this aspect. And finally, we have only to reposition the soft tissue, pulling the thread and pulling this way the soft tissue in the opposite direction. And it's not important to overcorrect. You see, at the end of the procedure, with this technique, we have a slight deformation of the face. We have to inform the patient about this. And this deformation will disappear usually after 1 or 2 days. And of course, when we cut the external part of the thread, the dimpling of the skin reduce. And if we have some dimpling, we can apply a slight pressure to reduce it. But when I have this type of dimpling of skin, I ask to my patient to wait few days, because this dimpling indicate a good interaction between the thread and the soft tissue, and this help to maintain a good final result. Okay, some cases. In this patient, we performed the lateral reshaping, so we reposition all this fat compartment, and you see that the final result in three-quarter view and in frontal view is absolutely good, with a good definition of the contour of the face. And here you have another patient that you saw in the video with a good definition of the jawline and of the malar area. And in this young lady, you see a good contouring of the face, but you can see that in this case we enlarge slightly the face. This is not a problem in this specific type of patient, but in patient with a wide face, probably this is not the good technique. And here you can see also the improvement of the quality of the skin due to the biorevitalizing effect that we have with this thread. Another case with a good contouring, and finally I finish also this presentation. Okay.
So there are a few questions you want to answer that. What about the results in photo-aged skin?
Sorry?
What about results in photo-aged skin?
Okay. Yes, of course. In photo-aged skin, you can have probably a less effective action of this procedure. Mainly, you can have also quite long-lasting irregularity of the skin, because you know that the elasticity of the skin in aged skin is absolutely lower. And I think that in this case, first would be a good idea to perform fractional laser or I don't know, other procedure as a biostimulation of the skin to improve the quality of the skin, and then perform the threads. And of course, the biorevitalizing effect of the thread can also improve the quality of the skin.
Yeah. So there is one question, I think you have already answered it. Dr. Vijay is talking about when should you correct the dimpling at the entry point if it is there?
Okay, so dimpling at the entry point usually is quite normal. Okay, and even if you are sure that you pass through the hole you created with the 18 gauge needle, some often you have a slight dimpling in this area. And usually this dimpling in Caucasian patients disappear after maximum 7 days. Okay, probably in Asian patient, and the arrow will confirm this. The duration of this dimpling could be longer, and so you have simply to explain to the patient that is something that will disappear, and that assure the good anchoring of the thread. And usually, especially women, have no problem to cover this dimpling with long hair, differently for men. Aro,
Yes.
how
So,
long is dimpling in Asia?
well, as you said, as much as possible, you really have to insert the needles in the same hole, because that's really going to determine how long the dimpling is going to last. Dimpling will almost always happen. Almost, it's something that will happen, and you really just have to reassure the patients that the dimpling will disappear. Probably anywhere from 3 to 5 days to a week. If more than a week, there's a pretty good chance you got some dermis that it hooked on some dermis, or you weren't able to enter the same hole. But more often than not, a week. Yeah, three, maybe 5 to 7 days.
So there is a one question from Dr. Ismail. During insertion, if I feel I am in the wrong plane, can I pull back and reinsert the needle?
Yes, if you checking the depth of insertion, meanwhile you are inserting the needle, you can withdraw the needle and change the insertion plane. But if you pull out the needle, you cannot go back. So you have only one option: cut the thread and use another. For this reason, it's very important to check constantly the right insertion plane. If we have some gaps, we move back the needle and we insert it again. And we pull out the needle only when we are sure that we are in the right plane.
And what about the thread? If it is, in the wrong placement of thread, same question from Dr. Ismail only, or some complication due to wrong placement. Is it possible to remove this type of thread?
Yes, it's possible. But of course, if you, and we will see how to do this in the complication part. You can remove the thread, creating a hole with the 18 gauge needle. Then with a small hook, you can try to fish the needle. When you catch the thread, sorry, when you catch the thread, you can extract it. Then you can try to remove it, pulling the thread. Of course, you can have some resistance due to the barbs. So you have to break the barbs and hoping that you don't break the thread meanwhile you are doing this. And so it's possible, but not so simple. But usually you have to remove the thread, in my personal experience, only when you have an infection. And the infection facilitates this procedure, because the infection reduces the interaction between threads and surrounding tissue. So it's quite easy to remove the threads.
Okay, that's it. We have no other question. You can go to next session, please.
Okay, so I think that next is Dr. Aro.
Yes. And next I'll be discussing the 3 techniques. Well, 4: ORV, ORH, STR 2 and 3. Okay, good afternoon. On this session, we'll be talking, in this part of in this segment, we'll be discussing about the oval reshaping technique, ORV, which is vertical, and ORH, which is the horizontal. When we use the Definisse double needle threads, it can be used for oval reshaping vertical technique. It allows you to reshape the facial frame, making the face more oval, lifting the mid and lower space superficial cheek compartments, providing a minimally invasive thread lifting of the lower face. Based on the doctor's level of experience, the ORV can be done using a 12 cm or a 23 cm thread. Now, when planning this technique, the first thing to do is draw the safety lines with any technique, actually, not just this one. So for all the techniques, it's very important to draw the safety lines. So the safety line 1 is from the lateral canthus to the tragus, and safety line 2 is from the medial canthus to the modiolus. After doing the safety lines, we then we identify the entry points. For the ORV, the entry point is in the pretragal area. I usually measure about 1 centimeter anterior to the tragus, caudally to the safety line 1. After determining the entry point, you have to determine the intermediate point, which is usually 2 cm anterior to the end point, also caudally to the safety line 2. So this is the in and this is the intermediate point. After this, we will now determine our out points. We will have 2 out points. The first out point is anterior to the angle of the mandible, which is here. And the second out point is superior lateral to the marionette line, which is this part. Now, after drawing these points, we can determine our reshaping lines. Our first reshaping line is from in to out 1. Our second reshaping line is from the intermediate point to out 2. Now, the line in between in and M indicates where the central part of the thread will be, the part without thread, and this is where it's going to lie. More or less, it's going to lie in this portion. Now, as you can see here, the vectors for what you call this doing an ORV is a diagonal lift. The vectors the directions are similar to the MR, but this one, instead of the MR pulls it laterally, this one pulls it upwards in a diagonal fashion. And then from this diagram, you can see it's able to pull up the middle cheek fat, the medial cheek fat, part of the superior jowls, and the lateral cheek. This is a minute. So here in this patient, it shows a patient with a wide face. It's characterized by ptosis at the site of the superior and inferior jowl compartments. So here, it's a little wide here to the lateral side of the mouth. Now, to effectively manage this patient, the patient's ptosis, we're going to adjust the malar fat pads. We will apply a 23 cm double needle thread to the ORV technique. So if you look at here, the first things we do again is we do the safety lines, safety line 1 and safety line 2. After drawing the safety lines, we can determine the in and intermediate points. The first in point is 1 cm anterior to the tragus. The intermediate is 2 cm from the first in point. And then after this, the out point, which is in the posterior portion, the first out point is anterior to the angle of the mandible. And the second out point is superior laterally to the marionette line. So that one is our first out point. And the second out point is there, superior laterally to the marionette lines. After this is done, we can, after we determine the entry and exit points, we also mark the reshaping lines, which are in blue. After we mark the reshaping lines, we will put some anesthesia, local anesthesia composed of lidocaine and epinephrine. I usually inject about 0.3 to 0.5 cc of lidocaine in each entry or and exit point. I usually only inject in the entry and exit points, but if you're more comfortable with it, some doctors inject actually along the reshaping lines. This is for the comfort of the patient. Now, after doing the injection, you have to sterilize the patient's face, make sure it's cleaned. You clean the hair, you clean all the whole face, anything that's going to be exposed during the procedure. So after this, after doing all the points and after doing the planning, when we do when we put surgical drapes, we start off by creating a hole in the entry point using a gauge 18 needle. Gauge 18 needle will puncture a hole in the skin big enough so that a thread and a needle can fit in the hole at the same time, because we will be reinserting a needle into the same hole. So if you look at this, once you open the threads, you have to make sure that check the threads, check the viability of the threads, make sure there are no loops. Make sure there are no loops or sharp angles in the thread. And also you want to check the strength of the thread. You can do this by gently pulling on the thread. So after this is how we insert it. Insert the first needle into the end point, and after inserting it, when you go through all the layers of the skin, you will feel a give, and that give signifies that you're already in the subcutaneous layer. By then, you can change the angle and make the direction of the needle more. You have to enter perpendicularly, but once you pass through all the layers of the skin, you will change the direction to make it move in a more it's parallel to the skin. It's a tangential direction and as parallel to the skin as possible. When you reach the intermediate point, you use again the needle cap to push the skin against the tip of the needle to ensure that it comes out also perpendicular to the skin to minimize the chances of dimpling in those areas. So after the needle goes out in the intermediate point, you just pull the thread until the area with no barbs, which Dr. Fundara is holding, that portion. Don't worry if for one reason or another you do not see or you forget to take note of the area with no barbs. The moment the non-barbed area enters the skin, it will be followed by the barbs going in the opposite direction. So right away you will feel tension and you will no longer be able to pull the thread out. Well, you can if you really pull hard, but you will damage the barbs. So after this, you put the needle again in the intermediate point, and once you're in the correct plane, move it slowly down towards the superolateral portion of the marginate line. And once you have reached this point, you exit again on the skin by putting again the needle cap, so that to ensure that it comes out in a perpendicular manner. So after pulling out the thread, the needle, pull it out, make sure there are no loops, and make sure there's no hair that goes into the loop that went here. And after this, you can proceed with inserting the other needle. The other needle is inserted into the entry point. And after, the reason why you use a gauge 18 is because you want to make sure you enter the same hole as the initial needle that was put in. Because if you inadvertently create another hole, you will have dimpling that will last much longer than a week or two. It may last even months, actually. So once the needle is in and you made sure that it was inserted in the same hole and you're in the right plane, just move down to your out one, which is the area anterior to the mandibular angle. So after the needles have been pulled through the skin, and the threads are in place, just cut the ends of the threads so that you can dispose of the needles. And as you can see here, here you'll be able to massage. You hold the threads. There's no need to pull on the threads. You just keep them taut and you massage the skin upwards. By doing this, you will engage the barbs. You will open up the barbs, and the soft tissues are going to hook onto these barbs. And after doing this, you proceed by doing the other side of the face. And the excess, after massaging the face, and repositioning the different superficial fat pads, you can cut the excess thread which is sticking out. When you cut the excess threads, if there is any dimpling, you just have to gently massage on the area. And as you massage on the area, you'll most probably disengage the barb which stuck to the exit point, and you will have better improvement. So in the exit points, you don't usually have dimple. If ever you're going to have a dimple, you're going to have the dimple in the entry and in the intermediate points. After cutting the threads, you just have to apply steri-strips, as Dr. Fundaro said. If the patient is amenable to putting steri-strips this way, this is fine. But if they're not amenable, you can just use small strips of tape and just cover the holes. So that is the ORV technique. The next technique that will be discussed is an ORH. The ORH is also used as a 12 cm double needle. The difference between all the other techniques that we discussed in this one is we will be using 2 threads per side of the face. An ORH technique allows you to vertically reshape the frame of the face, providing a minimally invasive thread lifting. Now, once again, safety line 1, safety line 1, and safety line 2. You have to draw them. Now here, you will have 2 entry points. There are no intermediate points for this technique. Your first entry point is in the pretragal area, 1 cm in front of the tragus. Their second point, entry point, your in2 is 2 centimeters anterior to the in1, both posterior to the safety line 1. After this, you will have 4 out points. 2 of them will be inferior to the in points and 2 of them will be superior. Your first out point is going to be on the mandibular angle, and then your second out point is going to be on the jowls. So here's your first out point, and this is your second out point. Out 1 inferior and out 2 inferior. Next, you will draw the out 1 superior, which is here. If you notice, we passed the safety line, and then the out 2 superior is also past the safety line over here. As we mentioned, you have to be very careful once you pass the safety line. So when the needles exit here, you have to be careful not to go too deep, because if you hit any of the superficial temporal vessels, you will have quite a big amount of bleeding in this area. Okay, so after drawing the out points, your reshaping lines are from in1 to out 1 inferior and in2 to out 2 inferior. You also have reshaping lines going upwards to out 1 superior and out 2 superior. Now, in the superior out 1 and superior out 2, it is also possible to re-enter these out points and make a J-stitch. If you do a J-stitch, you will increase the thread's holding strength. So it's very important to take note that every face is different and that treatment plan has to be adapted to the individual anatomy, face morphology, and the needs of the patient. So I don't have a video for this, but basically it's very similar to the ORV, but this one, the difference is it just goes up. It goes past the safety line 1. The next treatment that we'll be talking about is an STR technique, or the next technique that we'll be discussing is an STR technique. It's a soft tissue reshaping technique. Now, this soft tissue reshaping technique, here we don't use the double needle threads. We use a free floating thread. Free floating threads, the difference here are there are no needles attached to the ends of the thread. Insertion of these needles are done with the use of a spinal needle or a cannula needle, and it comes in 2 lengths. It comes in 12 cm and 23 cm. Now, just like the double needle threads, it has bidirectional converging barbs, and there's an area in the middle that has no barbs. The nano part of the threads also do not have barbs. So if you look at this, if you look at this, if this is the middle of the thread, more or less it's about 1 centimeter long, and from this point to this point, you have 6 centimeters of barbed thread. On the other side of the thread, it's the same thing. You have here, from this point to this point, you have 6 centimeters. And the lateral parts of the thread, which is more or less 5 centimeters, this part and this part, 5 centimeters. If you notice, there are no barbs in this area. So, so in soft tissue reshaping technique, it allows you to reposition the tissues of the malar fat compartments, remodeling the treated area. Now, STR, there are 2 STR techniques. You have your STR3 and your STR2. The difference basically is the STR3, you will be using 3 threads and 3 threads or 3 pairs for the whole patient. In STR2, you will be using 2 threads or 2 pairs for the whole patient. Now, STR3 is usually used for patients with moderate ptosis, and STR2 is usually used for patients with mild ptosis. The implantation of the threads are usually used, for implantation of the thread, we usually use a 9 centimeter spinal needle. Usually gauge 19 or gauge 20 is suggested. Now, once again, here we are again with the safety lines. It's very important to take note of this all the time. Yeah, draw your safety line 1 and safety line 2. Once again, lateral canthus to tragus, medial canthus to modulus. After doing your safety lines, you will have the next thing to do here is you have to identify the target area. The target area is the area that you want to treat. The free-floating threads are usually, the indication for a free-floating thread is you want to fill up or you want to bulk up the target area. So if you have patients who have already thinning or atrophied atrophied medial superficial fat compartments, this is what you want to do. You want to augment this part. Now, in females, this part is usually more anterior, and in males, this part is usually more posterior. Now, after identifying the target area, you will have to identify 3 entry points. The entry points here are all on the safety line 1. Now, entry point in 3 is 3 centimeters from the lateral canthus. From this top point to this point is 3 centimeters. Your next is the in 1, which is 1 centimeter from the in 3. And your next entry point is in 2, which is another 1 centimeter from in 1. So basically, after drawing your safety line 1 from the lateral canthus, you can use a ruler and you mark on the patient, mark on the safety line 3 centimeters, 4 centimeters, and 5 centimeters. Those are going to be your 3 entry points. So after determining your entry points, you have to determine the 3 exit points. Your exit point 1, the first one is the out 1, which is 2 centimeters from the medial canthus. Your next is out 2, which is 1 centimeter from the out 1. And your last out, which is the out 3, is 1.5 to 2 centimeters from the lateral corner of the mouth. After determining all these, you can determine your intermediate lines. So you can see here, basically it's from in 1 to out 1, in 2 to out 2, in 3 to out 3. You will also have to determine an intermediate point. The intermediate point for free floating is usually the middle of the target area. Now, how does this work? These are how the vectors work for this. For this line is actually your in 1. So the in 1, this is the reshaping line of in 1. And then the reshaping line of in 2 is parallel to in 1. And the reshaping line of in 3, it goes down towards this is the in part, in 3. It goes down to the target area, and as it reaches the intermediate point, you will have to change the direction of the needle and go down towards the corner of the mouth or the modulus. So after this, so these are your in points. These are the vectors. Now, as I mentioned earlier, this part is the area which you want to bulk up tissues. I will skip some slides, but if you remember Dr. Fundaro's lecture, he mentioned that the threads are bidirectional converging threads. Since they are bidirectional converging threads, when you pinch and massage the tissues, it will converge in the soft tissues will accumulate in the middle of the thread. Now, because of this, we have to make sure that the area of no barbs is in this area, in the target area. So to be able to determine that the area with no barbs is in the target area, you will have to measure the length of the thread. Now, how do you do that? The formula that we do is A to B plus B to C is 11 centimeters. If you remember earlier, I said from the non-barbed area, which is this part, you have about 6 cm of barb here, and you have another 5 cm with no barbs here. So A to B is most probably the non-barbed area, and B to C, most of the barbs are in this area. And this is the from A all the way to C here, that's 11 centimeters. It's the same thing with the other end of the thread. C to D and plus D to E is also 11 centimeters. But if you notice, this is much shorter. You will probably have barbs coming out of this part because it's a much shorter distance. So that's how to determine that the non-barb or the center of the thread is here, because that's where you want most of the bunching to occur. So this is how it works. If you have the bidirectional converging threads, you will have accumulation of tissue in the middle. Now, after carefully anesthetizing and disinfecting the areas to be treated on the patient face, you insert the cannula needle along the course of the reshaping lines. After inserting it, take out the trocar, insert the thread. And when the threads are inserted and you're sure that the midpoint is in the target area, you fix the thread with one hand and then you pull the cannula out with the other hand. After doing this, cut the threads close to the skin. And after closing the skin, you have to massage. You can hold again the sutures. You just keep them taut and massage the skin and pinch them. You can pinch the skin this way. I have a video to show you how it's done. And after pinching, you can cut the excess excess thread and apply steri-strips. Wait a minute. So in this patient, well, the reshaping lines in this patient in this video is a little different, because if you notice from the presentation that I made, in one usually goes, in the presentation that I presented, in one goes out here and in two goes out this way. They're supposed to be parallel, but it will really depend on the experience of the doctor, of the one who applies the threads, because if you notice here, all the threads crisscross. In the presentation that I gave, in the reshaping line 1 and reshaping line 2 are parallel to each other. So I guess it will really depend per patient, because depending on what tissues you would want to lift and what superficial fat areas you want to reposition, that's going to determine if you're going to have parallel reshaping line 1 and reshaping line 2, or reshaping line 1 and 2 that are going to intersect with each other. Here also, you will notice the reshaping line of the thread. The third thread is the same as what was presented. It goes down to the intermediate point, and as it goes down to the intermediate point, the needle will change direction and go out to out 3 over here. So in this patient, this is how it's done. After anesthetizing and sterilizing the face, you insert the spinal needle into the, I believe that's in one, and you course through, make sure that the patient doesn't feel any pain. You can pinch the sides. You can pinch the sides of the cheek to make sure that there's fat and you're going through the fat tissues. If there is any resistance and you don't see the skin rippling, you're probably hitting this mass. So as you go out there, you can pull out the trocar, and right now you put the thread inside. So the thread is inserted into the needle. And after measuring and after determining that it's in the middle, you fix it with one hand and you pull out the needle. Once you pull out the needles, the barbs are already engaged, and that is how you massage the tissues so that they will be bunched up in the middle. Just hold the thread with one hand, and with the other hand, you pinch. It's a pinching motion. Previously, it was a massaging motion wherein you massage in the vectors. This one, you pinch so that the tissues will bunch up in the area. Here, another thread is inserted. This is the insertion of the second thread. Some doctors ask, is it possible, since you're intersecting the needles, is it possible to actually cut? I guess it's possible. I haven't seen it happen, but how I do it is, if there's any resistance whatsoever, just pull the needle back. Pull the needle back to avoid, well, one is to avoid hitting the smash, and also maybe if you're hitting another thread, there might be some resistance, so just pull the needle back. Once again, after determining that the middle portion is in the target area, fix the needle with one hand and fix the thread with one hand and pull the needle out with the other hand. Then once again, you can pinch. Usually what I do is I only start massaging after I insert all threads. I wait to insert all 3 threads, all 2 or 3 threads, and that's the only time I massage. After doing that, after massaging, you can cut the excess threads. So this is the 3rd thread. If you can see, once the applicator reaches the intermediate point, the direction of the needle changes and it goes downwards. It's more posterior. You do this so that you will be able to reposition the superior jowl fat, and some of the superior jowl fat will be moved more cephalically, in a cephalic motion. So there again, determine that it's in the middle, fix with one hand and pull out the thread. And once again, you measure. And after measuring, pull out the needle, and you cut out the excess. So just like the other techniques, you just have to cover the entry and exit points with steri-sticks. So the last technique that is going to be discussed is an SDR2. The difference, as I mentioned, with SDR2 from SDR3 is we will only be using 2 threads. So once again, start off with drawing the safety line 1, safety line 2. The difference, and then after this, you determine your target area. The difference here with your entry points is your first entry, or the into, once again, is 3 centimeters lateral to the lateral canthus on the safety line 1. And your in one is 2 centimeters away. So it's not 1 centimeter, it's 2 centimeters away. What I do, after drawing the safety line from the lateral canthus, I mark on the side of the face 3 centimeters and 5 centimeters. Those are your 2 entry points. So after marking those 2 entry points, you have to mark your exit point. Your out one is going to be 2 centimeters from the medial canthus, and your out 2 is going to be 1.5 to 2 centimeters from the lateral corner of the mouth. Once again, you determine an intermediate point, which is the target. It's in the middle of the target area, and the needle, when the needle in 2 crosses the intermediate point, you will have to change direction going down to out 2. These are the reshaping lines. This is in 1 going to out 1. And the other reshaping line is in 2 going to out 2. As the needle passes here, when you hit the intermediate point, change direction going downwards. So once again, this is your target area. You have to make sure that the middle of the thread is here. As I showed you a while ago, the formula for this is A to B plus B to C is 11 centimeters, and C to D and plus D to E is also 11 centimeters. It's really up to you if you want to measure from this point to this end of the ruler, this end of the thread, or from here to this end of the thread. It's up to you which you want to do, but both of them should be 11 centimeters. So same thing, it's the same process of putting in the SDR piece. It's just that you will only be using 2 threads. Once again, it is very important. Treatment has to be adapted to the individual anatomy and face morphology and needs of the patient. And that concludes my discussion of the SDR technique, SDR, ORV, and ORH techniques. Are there any questions?
Yeah, hello.
Yes.
So there is a question. One question was there, do you give antibiotics after threads?
Yes, as there was a form I mentioned earlier about what we ask patients to do after. So that's one of the things we usually give a short-term antibiotic, about 5 days, mild antibiotic to minimize the chances of infection.
So there is one more question, is not a question, but there's a request to share a video if you have for barb thread removal.
Oh, I'm not sure if I don't have one. I'm not sure if Dr. Fundaro has.
Okay, I think that I have one video in a cadaver head, and but I have to check with Relife where is this video, because I don't know exactly, but something I have, and so if it's possible, I will try to find it and send to India, Menarini India, and they can share it.
Sure.
But
There's
I
one-
have to check. I'm not sure, but I will try to find it.
There's one question from Dr. Dinesh. Can two different techniques be combined with same patient, like MR with ORV or ORH?
Yes, as well, Dr. Fundaro mentioned it earlier. He usually just uses one pair or one technique per patient. The simpler it is, I guess, the better it is. Less you will expect less complications. But yes, it is possible. It also depends on the, once again, it depends on the patient, because some patients will come in and they say, oh, doc, my nasolabial folds are too low. So, okay, we'll do an MR. Oh, by the way, my jowls also, I think I want it more defined. I want it more V. I guess that's amenable. I mean, I've done that. I've done that several times. I actually know I do that regularly, wherein I combine two techniques. But as at most, I will use two techniques per patient.
Yes, and usually when you combine two threads, you have a better repositioning of soft tissue, and probably also the duration of the treatment will improve.
So there's a question from Dr. Ismail. He says, among all the techniques, which one is commonly performed and most popular? This is one question. And the other question is, if you're using a thread, if you're using any energy-based device after 3 months, can it prolong the result of threads? So threads after 3 months, energy-based device, will that prolong the result of threads?
In my experience, the most popular is lateral reshaping, then probably metal reshaping technique, similar to JR technique, and less often I perform oval reshaping B or oval reshaping H, but it probably is due to the characteristic of the patient that usually I treat. And your favorite techniques, Aro?
Me, the ones that I do most here is what you call this, is I use a free floating, an STR2. A lot of patients that I see have flattened malar areas, and since it's flattened, I mean, as they age, it flattens. You have two options. It's either you fill it up or you put thread. But as I tell patients, if you put a filler here, basically what happens is you fill up this area, it looks more youthful, it's plump, it's more youthful. But the reason why it flattened out was partly because of atrophy and partly because of gravity. So when it went down, the fat is still here. If you use in an STR2 or an STR3, you're actually able to reposition the fat that's here and bring it back up here. So I feel that it's a more natural look than putting fillers.
And the other question is, after you use any energy-based device, after 3 months, can it prolong the result of threads?
I think yes. Of course, you combine two techniques that more or less as the same final aims. So I think that it's so because you improve again the quality of the skin, and I think that it could be absolutely.
So there is no more question. We can go to the next session, please.
Okay, great. So I think that now I have to describe the complication. Okay, good. Let me see. Okay, so what about complication? Because of course, as all the procedure we perform, also definite threat may have some side effects and complication, and so we have to well know how to manage them and solve them. So it's very important to keep in mind that the complication can be reduced or prevented with an appropriate knowledge of anatomy and a proper patient analysis. So spend time to perform an adequate assessment of the patients. And remember that this is a sterile procedure, so respect the sterility to avoid the infection. And also the correct anatomical plane is absolutely fundamental aspects of this technique, as we said in our presentation. And it's also important to give some post-treatment instructions to the patients, because an informed patient has a fundamental role in the achievement of a good result. So what about the side effect? In my opinion, side effects are not a problem. And because they are self-solving, we have only to inform previously the procedure that they can have this side effect. If patient is well informed, side effects are not a problem, and they are well accepted. And so bruising, of course, as in filler or botulinum toxin injection, can happen. Sometimes we can have a slight neural pain or paresthesia that lasts less than 1 week. Again, this is not an important problem because with paracetamol, usually you solve it and you can manage it. Edema and slight inflammation for 1 week is absolutely normal, and also skin dimpling and the irregularities are not a problem because they usually solve spontaneously. But of course, you have to inform the patient about this. And also asymmetry. Asymmetry is absolutely normal immediately after the procedure. Usually after 1 or 2 days, it disappears. Difference are the complications, because usually you have to manage the complications. And so we need to well know and understand how reduce the rate and how manage that. So the one complication may be hemorrhage or hematoma. These are due to a damage of one of the main vessels, arteries or veins, and usually is due to the incorrect incision plane. Means that we inserted the needle deep to the smash plane, because deep to this plane we have the main vessel. So it's very important to control the insertion depth and respect the safety line. If we have hemorrhages or hematoma, first of all, I suggest you to pull a little more the threads, because pulling the threads you can sometimes stretch the bleeding vessel and reduce the bleeding in this way. And then apply compression and ice pack at after 48 hours. Eat with a warm washcloth, for example, and sometimes application of vitamin K based cream may be useful. The last option is a surgical drainage, but I think that this type of hematoma usually doesn't need this surgical drainage because we have no dissection plane, and so hematoma probably will stop spontaneously, and I think that surgical drainage is improbable. And here you see the main vessel under the smile plane, so it's very important to insert the thread far from this dangerous plane. Neural pain and paresthesia that last more than 1 week. This may be a problem. Again, wrong insertion plane and excessive pull of the pulling of the thread are the causes of this complication. So don't overcorrect and again insert in the correct insertion plane. We can manage this problem with paracetamol or other painkillers. I have only one case of neural pain last more than 1 week, but I have to say that the day that I called the patient for the thread removal, the patient said me that the pain disappeared, and so I have now to remove the thread. So I think that if we wait a little more than a week and we try to explain to the patient that waiting probably these symptoms will disappear spontaneously, we don't need to remove the threads. And skin dimpling, long-lasting skin dimpling irregularities are due to the fact that some barbs, hooks, the dermis at the level of entry and exit holes. So it's very important to introduce accurately the needle through the entry point in the same direction of the hole, and the exit at the exit point, the needle pass through the skin in a perpendicular way. If we have this problem, we can massage the area in a strong way, perhaps injecting this area with lidocaine to reduce the pain. And usually we can perceive a click due to the barb that have disengaged from the dermis, and in this way we usually solve the problem. Sometimes we need to cast the thread close to the hooked portion of the skin, and we can cut it, creating a hole with an 18 gauge needle, and with the tip of a scissor we can cut the thread. Of course, we need the injection of local anesthesia and epinephrine before to do this procedure. So here you see that it's very important to insert the needle through the hole we create with the 18 gauge needle, and this specific part of insertion techniques is absolutely important to reduce the duration of dimpling. And here you see an Asian patient with dimpling of the skin at the entry and exit point. Of course, in this specific type of patient, we have a long-lasting duration, long-lasting dimpling, because the thickness of the skin determines this problem. And so in this type of patient, we can simply inform them that they may have long-lasting skin irregularities. And in this type of patient, it's very important to pay attention to insert and pull out the thread in the correct way. So if we have a permanent asymmetry, this complication is due to the fact that on one side the thread doesn't work, and this complication is solved in a very simple way, because we have only to insert a new thread on the ptotic side. Thread may be visible, and we can sometimes palpate the thread. Again, this is due to superficial insertion of the thread. So again, accuracy in thread insertion is absolutely fundamental. Again, we can apply a vigorous massage along the thread. We can also sometimes inject saline solution along the pathway of the thread, because this can reduce the engagement of the dermis due to the too superficial insertion of the thread. As a last option, we can remove the thread, but sincerely, I prefer to speak with the patient. I explain that this thread is an absorbable thread, and if we wait a little more, if she continues to massage the area, this problem usually will disappear without thread removal. Sometimes we have the migration and the visibility of the thread, and in this case, we have simply to remove the superficial and visible part of the threads. And again, we create a hole with the 18 gauge needle, and with a very small hook, we catch the superficial part of the thread. We extract it, and then disinfecting the skin and the thread, we cut the superficial and external part, and we solve usually in this way. Sometimes we have the spontaneous extrusion of threads, and again, in this case, the solution is quite simple. We have only to disinfect the skin and the external part of the thread and cut it, and in this way we solve the problem. But pay attention, if we have some sign of infection, probably we have to remove all the thread, but usually the spontaneous extrusion doesn't determine an infection, and so we have only to cut the external part. Okay, what about infection? Infection is a quite severe complication, and if we have an infection, probably is due to the fact that the sterility was not adequate, and also the antibiotic therapy was not adequately done. So it's very important to insert the thread respecting the sterility, and we have to disinfect the skin, and we have to use only sterile tools and instruments, and of course, usually if I insert more than one thread per side, I prescribe a post-treatment antibiotic therapy. And if we have infection, we can start immediately a systemic oral antibiotic therapy. But if this therapy doesn't work within 1 week, 10 days, I suggest to remove a thread, because you know that when we have an infection of a suture thread, probably and often the solution of this complication is the thread removal. And again, we have to create an 18 gauge needle. Then along the pathway of the thread, and it's quite easy to identify where is the thread, because usually the skin is red along the thread, and you palpate it, and then you have to catch and fish the thread, and using a mosquito you can remove it, because the inflammation surrounding the threads reduce the interaction between barbs and the soft tissue. So it's not so difficult to remove the thread, but it's very important to remove all the threads. And if you break the thread during the extraction, you have to create another hole, catch the remaining part of the thread, and remove it, because you know that the infection runs along the thread, and so it's very important to remove all the parts of the thread. And finally, Seattle cell. Seattle cell is due to damage of the parotid gland. It could determine also by damage of Stensen's duct, but I think that this means that the doctor that creates this type of complication has no idea about the insertion plane, because Stensen's duct is absolutely deep structure, and so you have to insert in an incredible wrong way your needle. But the damage of a parotid is not so difficult to determine, and especially in patients with hypertrophic parotid gland. So check your patient, check if they have a hypertrophic parotid gland. If you have some doubts, you can do a ultrasound exam. And if you have, of course, also the insertion is a fundamental phase of the procedure. So respect the correct insertion plane, especially in this patient with hypertrophic gland. And if you have a shallow cell, you have two options. Or you can apply a permanent compression. This can determine some problem for the patient. And the second option is treatment with botulinum toxin. You can perform the aspiration of a Seattle cell and then treat the area with botulinum toxin. Here you see a case of Seattle cell, is a case of mine. And you see the complete solution of the Seattle cell after a few days after botulinum injection. But of course, we have a slight asymmetry of the smile, and this problem disappear after one month and a half. Okay, so I think, okay, no, sorry. It is very important to perform a good assessment of the patient, evaluating the individual anatomy, evaluating the asymmetry that could be present before the procedure, and remember to assess also the thickness of the skin and of subcutaneous tissue. This is a sterile procedure, so perform it in an adequate office, medical medical office. Disinfect the skin of all the areas that you are treating, and use only sterile gloves, gauze, needles, and so on. And finally, it's very important also inform the patient about the post-treatment instruction. So if patient has a slight pain, you can suggest paracetamol, for example. If they have swelling or bruising, they may prevent by the use of ice pack, but I don't like to give this type of information because I cannot check how long the patient will apply the ice. And you know that if they apply for a long time, they can determine some problem of the skin, but also for nerves. If we have some doubts about sterility, if we insert more than one cell per side, or if we prefer to be sure to prevent infection, we can suggest antibiotics after the procedure. And we have to ask to the patient to avoid to sleep on one side and for 3-5 nights. We suggest to not apply makeup for 24-48 hours. And when patient wash or shave, it's very important that he do this in a gentle way. And it's also important to avoid the excessive face and neck movements. And of course, no sun and no tanning beds for 2 weeks. And also important to avoid high impact sports for maximum 2 weeks, but also less in my opinion. And do not use sauna or a mass. I think that for 1 week is enough. And inform the patient that they can have no dental procedure due to the fact that they have to open the mouth, and this can determine some problem due to the disengagement of the thread bars. And of course avoid the face and neck massage. So it's quite important to inform the patient, because this part is a fundamental part of the treatment, and what the patient do at home, it could determine a good or a poor result. And so inform the patient about this aspect. Okay, so I think that I finish also the.
So I will request all doctors, kindly switch on their video so that we can take one group photograph. Kindly, all of you, all of you kindly, switch on your video, please. Just waiting for everybody to switch on so that we can take a good group photograph.
So we check who was sleeping or not.
Not that. Nobody is sleeping.
Yeah.
Yeah, Dr. Celia, Dr. Ashokan, kindly, if possible. It will be nice to see all of us in one frame. Dr. Rohan. Dr. Sudha, kindly put on the video. Waiting for others to put on the video, please. Yeah. Dr. Tapeshwar, please, if possible. Dr. Selva Prabhu, if possible, please put on your video. I think we are having some reluctance on some part. So I think Jatin, it's good to go.
Okay, sir.
Yeah. Please click a good photograph of all of us.
I assume he'll say once it's done.
Yeah, just waiting for few more to come, sir.
Ah, okay.
I think you take now without waiting.
Done.
Thank you. Thank you. So, so we have one question from one doctor. So that is, do we make the patient lie down or make them recline during the procedure? You are on the mute, Dr. Fandaro.
Usually I try to position my patient in a sit position, or not completely sit, but slightly downwards, because in that way I can check better the natural position of soft tissue and the effect that I reach. And so I prefer the sit position. Is quite a little more difficult to insert the thread in this position, but I prefer it. And you, Aro?
I mark the patient seated. So when they're seated, I mark them. And then after I mark them, I recline the table. So to almost just probably maybe 20 degrees, 20, 30 degrees, so that it's easier for me to insert the thread. But after I insert the threads, I sit them up again. And that's when I start massaging the tissues and actually do it in front of a mirror so that they can see. And then that's the only time I cut the threads.
Yes, yes. And before to cut the thread, it's very important to check
Get
the patient.
down, yes.
Absolutely, yeah.
So any final questions you can yourself ask doctors if there is question. Anybody wants to ask a question, you feel free to unmute and ask a question. You need to unmute, Dr. Batul. You need to unmute, Dr. Patel. Yeah.
Hi, doctor. It was a lovely lecture. Hi. I just want to get to know what were the, we saw so many techniques. If you have to just tell us each indication for each technique. So like if you would say that for JR, you should see the jowl. For the malar reshaping, maybe you could see. So only like maybe 2 indications for each would be easier for us to understand which technique we should use for which patient.
Yes, okay. Of
Currently,
course.
everything looks really nice. You feel like just, trying to do all of them. So if you just can help us out just to try to help us to understand, in a much more easier.
First of all, it's also interesting to evaluate the difficulties of these techniques, because I think that malar reshaping, JR, are quite easy technique, and so also a beginner can perform them without problem. More complicated maybe lateral reshaping, lower reshaping, vertical, and the oval reshaping H. Free floating STR are is a simple technique and quite easily to be performed. And concerning the indication, usually the name try to give this this idea, and the JR jawline reshaping is absolutely for contouring of the jawline. Malar reshaping is for lateral repositioning of the malar fat pad. The free floating technique with STR, that is the most popular technique for Aro, but for a lot of Asian doctors, is for increase the projection of the malar fat pad. And this is very important, especially in Asian patients that usually have quite large face. They have good volumes, and so they need only to increase the projection. And for lateral reshaping is my favorite procedures, because with one thread I can treat both the malar area and the jawline area, but this technique create a larger face. So we have to check if it is a good technique for the patient that we are treating. The oval vertical reshaping, the oval reshaping techniques, vertical and H, are good for create a more oval shape of a face. So for every face are the probably the best technique. Yes.
To slim the face.
Yes, to slim the face, because you move the volume you have here towards the central part of the face.
Thank you.
Do you have a comment about the indication?
My indications, well, of course, what the indications that you mentioned, Dr. Fundaro, but aside from that, I also base it on you really just as what I've been repeating in all the presentations. Every face is different, and it really matters what the patient says. So patient comes into your clinic and the patient says, "Doctor, my nasolabial folds are so deep already. What can we do about this?" So when they say that, and there's full the projection is okay, I would imagine I do a malar to address the nasolabial fold. If they say, "Doctor, my nasolabial fold is already so deep, and if you see it's thinned out," I'll tell them, "Okay, let's do an STR," because the STR will be able to bring up your projection and at the same time pull the nasolabial fat to make it softer, the line. Now, of course, if the patient says, "Doc, I want to look younger. Doesn't this look good?" Just look at how their hands move. If they say this, for me, that's an ORV. When they say, "Hey, Doc, look at this," when they do this. But if they do this one, I say MR. But if they do this, oh, that's an ORV. And of course, you have the JR and all that. If it's what do you call this? If you want a more defined jaw, you do a JR. But that's what I do. I just ask them what really bothers you, and just from their movement, that's what I suggest to them. I suggest, "Oh, maybe you would be happy with this," and you can literally go to the patient and put your fingers here and say, how do you like this, or how do you like this, or maybe you can do this, pull it a bit backwards, and more or less you can tell the patients that yes, this will most probably this is most probably how it will look like. It's just a subtle pull. It's not a facelift, but it's just a repositioning of the fat, and more often than not, they're happy with it.
Yes, but Aro, we have to remember also to the patient that doing this is very simple. Is more difficult doing the same with the thread. Yeah, yeah.
Of course, yes, of course. But I mean, just for demo, just for demonstration.
No, yes, sure.
Thank you.
So thank you, Dr. Fundaro. I think we will. I will take the privilege of thanking both the trainers, Dr. Fundaro and Dr. Christian, for the exciting, session. Very wonderful training. In fact, all in the chat box, you can see all doctors acknowledging that the, the session was very good, very informative, very interactive. And I will also take this opportunity to thank all the Indian doctors who took their time off on a Sunday evening to attend this long session. Certainly, it has gone beyond even 9 o'clock to 9:20 now. And we, look forward to see you trying our Definisse thread. The product is already available. You can get in touch with our, the CAM key accounts manager, and they will, provide. And also, we have medical license, doctor also in Manarani, who will also be, complementing your, wherever you need the assistance, or I mean, of a medical license, it will also be provided. So please get in touch with our team, and if there is any other support required for you to, we will be looking forward to do some hands-on workshops also. But obviously, all of you are already doing threads, so probably you don't need much of hands-on. But if it is required, we'll certainly plan that also with the doctors who. So just get in touch with our team, and let's work together to see that the Indian patients get, the benefit of Definisse. Thank you very much. Thank you for attending. Thank you all of you.
Bye.
Thank you.
Bye-bye. Thank you.